So leads in ECG can be of two types, as you all know. One is the limb leads, and the second is the chest leads. The limb leads, again, could be the standard bipolar leads and the unipolar leads. So what happens in the standard limb leads? I'm sure this is something that you would all be aware of already, is the lead 1, lead 2, and lead 3. Lead 1 connected to the left arm, right arm. Lead 2 connected to the left leg and the right arm. And lead 3 connected from the left leg to the left arm. This is followed by the unipolar limb leads. Unipolar limb leads are AVR, that's basically at the right atrium. AVL looking from the left right arm, AVL looking from the left arm, and AVF looking from the left leg. The letter A in this stands for the augmentation that was done. So what was augmentation? So in 1933, when these were introduced, when the limb leads were introduced, and the standard bipolar limb leads were introduced, Wilson 1933 said that if we create an indifferent electrode, which is called the central electrode, by attaching a resistance to overcome the skin resistance and attach all the electrodes attached to all the extremities and sum them up to 0, we will get only one active electrode, and the other would be the central electrode or the indifferent electrode. And the tracings that are then recorded are in the unipolar limb leads. The unipolar limb leads did not give very good recordings initially. So what Goldberger came up in 1942 with was augmentation of the voltage on these leads by 50%. So when this was augmented by 50%, we got what were traditionally, or what we now classically call, the augmented limb leads. The chest leads, again, as you know, are V1, V2, V3, V4, and V5 and V6.
So as we all know, electricity is flowing through the heart. So basically what you're doing in an ECG is you're just trying to see flow of electric current through the heart, right? And as we all know, there are channels in the heart through which electricity, there is an area where the impulse generates. And then through certain cells, the impulse goes from one part of the heart to other parts of the heart, right? So there are two predominant kind of cells. One are the, there are several, but the predominant ones that we are interested in are the conduction cells. So all that is happening is that within the heart, there are specific areas that have formed bands through which electricity generated from one part of the heart flows to the other part of the heart. And then there are contractile cells which are responsible for mainly your pump function of the heart. Now, why is this important? Is because when electricity or impulse is flowing from these conduction bands, the speed of electricity or the speed of impulse is much faster in these conduction cells as compared to the contractile cells. And that is why when we talk about heart blocks, when we talk about things like we say there is a bundle branch block, and we will see what these bundles are, electricity cannot flow through these conduction cells because there is some sort of a problem in these conduction cells. And that is why whenever you have a block, like lower down in the heart, what you see is change in the morphology of the QRS, because instead of going through a streamlined conduction system, it is now trying to go like jumping from cell to cell rather than going through an insulated cable. So we were talking about leads, right? We just talked about the limb leads and the chest leads. Now you have to understand that they are looking at the heart from different planes, okay? So if this is your heart in the center of the chest, there are some leads which are cutting the heart like this through the which we call as the frontal plane, like this, and then you're cutting the heart through the horizontal plane. Now, horizontal plane means that it will only look at the impulse which is coming from the heart into the chest, like, straight forward into the chest or on the back. Okay, so they will only look at the heart in this axis. But the frontal planes will look at the electricity in this axis. Okay, and this is very important. So anytime you don't understand this, please stop, because this is going to be the basis of whatever axis derivations and everything we are going to form. Okay, so yeah, so the implication of this being that whenever there is depolarization, and we will see what depolarization is, basically electricity is going from the top of the heart to the bottom of the heart, or the top chambers of the heart to the bottom chambers of the heart. The limb leads are the ones which are in the frontal plane, and that will help you see what the axis of the heart is, okay? Axis of conduction is, or basically axis means in which direction is the predominant flow of electricity, okay? And these ones will look at mostly left or right because they are cutting the chest across and they are placed across the chest from right to left. They will help you see if the electricity is predominantly flowing from right to left or left to right. And the frontal planes will help you see if the electricity is flowing from top to bottom or bottom to top of the heart in simpler terms, okay? And in the ECG, what you're looking for is actually a predominant vector because every area of the heart is capable of giving you a beat, right? But they are very tiny areas and tiny things. All of these then sum up to form a predominant direction of electricity flow, which you can then see based on the frontal plane or the horizontal plane. Now, that is again very important. So if you don't understand, please stop us because otherwise, there's no point of this lecture. And then coming to where we place these leads, okay? So we were talking about frontal planes. So the basic concept of all of these leads is you're trying to make the electricity flow from a negative area to a positive area, okay? So all you're doing is the electricity is flowing from a negative area and from a negative side to a positively charged lead. So what you do is you put 4 leads. One is an inactive lead, which is your right leg. It basically serves to ground the lead. And other than that, you have 3 active leads, which you have the right arm, the left arm, and the left leg. And you can place them either on the wrists or the leg, or you can place them up top. But basically what you're doing is you're trying to make the electricity go through the heart, which is in the center. Okay, and we'll see more of that in the next. Okay, so this is what we were talking about, the electricity flowing, okay? So you have lead 1 in which you have a positively charged lead which is in your left arm, and the electricity is flowing from the right arm to the left arm. So basically what you're doing is you're cutting the heart at a 0-degree angle. So look at the figure on the right. So you have lead 1 in which electricity is flowing from right arm to the left arm, and you're making a 0-degree angle with the heart. Okay, that is your lead 1. So even though on the figure it appears that it's going only from the arm, when you look at the figure on the right side, which is the circle with all the leads, that is the angle, or that is the axis it's making with the heart. Then you have lead 2, which is right arm to left leg. And then you have lead 3, which is left arm to left leg. So in summation, when you see all these 3 leads on this big circle on the right, lead 1 makes an angle of 0-degree, lead 2 makes an angle of 60-degree, and lead 3 makes an angle of 120-degree with the heart. Okay. Now what we did, and this is all by convention, okay? You could have named all of this as 360-degree angles, but just the way we have named it, it goes from 0 to 180 and then it goes negative in the opposite direction. It's just convention because that is the terms which people use to communicate with each other. And then what we did was like Dr. Goel was saying, that we didn't have any significant, we got augmented leads, so now we needed more limb leads. And what we came up with were these 3 leads, okay? So simply the way you remember is AVR, R for right, so it is looking at right side of the heart, okay? And it's making an angle of 150 degrees with the heart. Then you have AVL, simply it's looking at the left side of the heart, L for left, R for right, it's making an angle of 160 with the heart. And then AVF, F for foot. So it's looking at it's connected to the left leg. It's looking for the foot and it makes an angle of 90 degrees with the heart. Okay, so these are your predominant angles. And eventually the goal would be to memorize this figure. All you have to remember, lead 1, 0, lead 2, 60, lead 3, 120. So 0, 60, 120. And in between, when you put things, you have negative 30, plus 90, and 150, and then the opposite would obviously be the opposite.
Manav, you have something else to ask?
Yes, sir. Sir,
Go.
in case the current in the heart is along the line, in that case, that axis records a zero current.
No,
No.
if it's in the same line, it records positive. Okay, along the line means it's in the direction. Okay,
Correct.
so if it's like, let's say lead 2 is 60 degrees to the heart, so anything which is going towards will be positive, and anything which is perpendicular, so anything which is 90 degrees to that lead will not record anything. So
Correct.
towards or in the same direction will be positive, in the opposite direction will be negative from the baseline, and anything which is 90 degrees, okay, perpendicular, that means that there is no current that the electrode will pick up. So that will come as a flat line or something. So that will not be recorded as anything. So same direction is positive.
So if you're looking at this lead 2, and if this is the heart behind, then if there is a current which is flowing, let's say in this septum, this is the septum, the orange one. If the current is flowing
Okay.
like this in this septum, then the recording will record something like a positive deflection. Whereas if it was, let's say, the polarization
Sir,
of this
positive for which lead?
lead, I'm all talking about reference lead 2. So this is
Okay,
the
sir.
direction of lead 2. This is the direction of lead 2. So if the current is flowing
Okay.
like this, that means it's almost oriented to the 60-degree axis, and it will record a positive deflection. Whereas if the
Okay, sir.
right ventricle was getting depolarized, and this direction would usually be like this, and this is practically in the direction opposite to the lead 2. That means it's going in the opposite direction. This is the direction of lead 2, but this is current is going in the opposite side, so it will record a large negative deflection, practically like this.
And we will get a zero. Sir, can you show when we will get a zero for this lead
If
on
this is
the
the
same
lead,
diagram?
if
Yeah, so
this is
let's,
going anything like this
Okay,
or
sir.
in the reverse
Fine.
direction. Yes,
basically
Sonal.
90 degrees to it.
Okay, sir. Right.
Okay. Okay, so now let's
Yes,
go
sir.
ahead from this.
Okay, so yeah, just summing everything up. Okay, so you have lead 1, which is, you know, cutting the heart at 0 degrees. You have lead 2, which is cutting the heart at 60 degrees. Lead 3 cutting the heart at 120. And then you have the augmented leads, which are in between the leads. Why are we saying this again and again? Because we will use this thing in the rest of the lecture. So that is why it's important. It will also help if you guys want to pull up one of those diagrams that we had in the last slide, you know, on a phone or something, or on your computer when we are talking about access in the future. That will just help you reference to that diagram if you can't remember them now, because you just can't remember them looking at it for the first time. So yeah, and this is just where we will stop for now. So now all of this was, like we said, you know, 60 degrees, 0 degrees, all of this was from top to bottom or bottom to top. Now, what about right and left side of the heart, right? So electricity will not only go from top to bottom, it will also travel towards your chest wall, right? And it will also go left and right. So for those, what we have are the chest leads or the precordial leads. And the way they are arranged is this V1 is the only electrode which is supposedly a right-sided electrode because it is to the right of the sternum, okay? And everything else comes on the left of the sternum in a serial angle, okay? So you just go by intercostal spaces, and then you keep arranging it till you come to the mid-axillary line. So you keep going down an intercostal space, and then you come down to the mid-axillary line, which is your V6. Now, as you can see in this, the leads are looking at specific parts of the heart, and that is why these leads have terms. The reason this is important is because logically, what will happen is one area of the heart will depolarize, you know, at a time. So it will be the anterior wall, the inferior wall, the lateral wall, the septal wall. And that is why if there is something affecting one area of the heart, it should ideally be reflected in the leads looking at that particular area from whatever angle, right? It could be from top, it could be from front, you know, like right to left. So that is why we name these leads as lateral leads, which look at the lateral wall of the left ventricle, so V5 and V6. In the precordial leads are lateral leads. V3 and V4 are looking at the anterior wall, so they are anterior leads. V1 and V2 are looking at the septum. That is why they are called as septal leads, okay? And like Prabhat said, that these were named by Wilson, so they're just called Wilson central terminal, okay? So again, that is, and we will see it again in the next slide. That is why we have leads looking at specific areas of the heart, okay? So now when you combine the precordial leads and you combine the frontal leads, you will get several combinations of leads which are looking at one area of the heart, okay? So the lateral wall, as you remember, the lateral wall, you had 1 and AVL looking at the left side of the lateral wall. So 1 and AVL will be one of those leads. And then the AVR was looking diametrically opposite, right? AVR was looking at diametrically opposite. So you have negative of AVR. Yeah. Okay. So AVR was looking diametrically opposite. So when you do the negative of AVR, what you will get is a lateral wall area. Next is your anterolateral. So little anterior, but some lateral. So V5 and V6 are those leads. Just anterior are V3 and V4. Inferior are the 2, 3, and AVF, because all of them were, if you remember, 60 degrees, 90 degrees, and 120, right? So in that area of the heart, so inferior. And the septum are V1 and V2. Now, as you can clearly see, what we are missing is we are never getting a proper look at the right side of the heart or the posterior heart, and that is why we have device leads. We don't always get them. You can make some conclusions looking at the leads that you already have, because the posterior wall or the right side will be opposite to the left side, right? So you can draw some conclusions from there, or you can put some leads on the right and sometimes look at that when you're concerned about the right-sided in problems. I don't mean right ventricle, I mean right side of the left, like the left ventricle, which is looking towards the right.
Yeah, so there is a question by Devendra Swami. So Devendra, I have unmuted your mic. Go ahead and speak.
Yes, ma'am. My question is the position of the chest leads in which intercostal space?
Oh, so I mean, usually you start with second intercostal space on the right, then second intercostal on the left, then you come on the third, then you come on the fourth, and then in the fifth you go on to the anterior axillary and mid axillary.